Hi, everybody, and want to welcome everybody to the first symposium of CAHR 2024 called Individualization Concepts in the Management of Persons Living with HIV and What Does This Mean? I'm grateful to have the opportunity to be in front of all of you today, and I want to thank the conference organizers as well as Mark for the opportunity to present. So I want to begin with our land acknowledgement. CAHR 2024 is taking place on the traditional lands of the Anishinaabe, Hodun Nonshawe, Len Apewak, and Adawandaran peoples on lands connected with the London Township and Sombre Treaties of 1796 and the Dish with One Spoon Covenant Wampum. This land continues to be home to diverse Indigenous peoples whom we recognize as contemporary stewards of the land and vital contributors to our society. My name's Alex Wong. I'm one of the infectious disease physicians in Regina, Saskatchewan, Canada, and again, it's a pleasure to be in front of all of you for the opportunity to present today with this symposium. Along with me is my colleague Bertrand Labouche, Associate Professor in the Department of Family Medicine at McGill. And you can see here the various symposium objectives today that we're going to work through over the course of the next 45 to 50 minutes. So this symposium, I'm going to just begin with my disclosure conflicts, just all listed there. So I put this slide up first, and it's meant to be a bit of a haha, really another NNRTI. This was actually a slide, this was the title of our CAHR symposium from 2019, which was actually in Saskatoon. It's hard to believe it was 5 years ago. And we put this up because at that point, doravirine had just been approved by Health Canada for use, and the entire discussion was around, like, do we really need another NNRTI? You know, why is this even useful or relevant? And again, it's hard to believe and just reflect on the fact that 5 years has gone by, and we're going to go through some data that we have for doravirine, some use cases for the product, and where it continues to fit in the current ART landscape. This was Saskatoon, which in many ways is similar to London. I actually completed medical school here, and so just as the Thames runs through London, Ontario, the North Saskatchewan runs through Saskatoon with the bridges and so forth. So I just want to begin with a very high-level overview of NNRTIs and their use both past and present. So historically, we had efavirenz and rilpivirine as the most common NNRTIs in use, and something called etravirine, which was used mostly in individuals with treatment experience. Efavirenz was a very good drug, excellent potency and durability, and it never was beaten sort of virologically head-to-head in clinical trials for over 20 years. And then its other major claim to fame was that it was part of the very first single-tablet regimen co-formulated with FTC and tenofovir, or so-called ATRIPLA, which was available in 2006, and this was the very first one-pill, once-daily regimen that could be used to treat HIV. However, there were issues and concerns with efavirenz, the big ones being central nervous system toxicity, elevated liver enzymes. Initially, there were concerns with regards to its safety in pregnancy, although those have kind of largely been put to bed now. You could get rash, and then there was the issue with elevated lipids and the so-called low genetic barrier to resistance. Rilpivirine was kind of like a next generation NNRTI, which then became available, and it was available on its own as a pill, and also co-formulated initially with TDF-FTC, or so-called Complera, and then subsequently with TAF-FTC as Odefsey, both for ART-naive and ART-experienced individuals. And it was also subsequently co-formulated with dolutegravir as a two-drug regimen as a switch option for experienced individuals as well. It's made a bit of a resurgence as well lately because it's now being used together alongside cabotegravir as part of the long-acting injectable regimen that's being used more widely now. And again, it's well tolerated. It has a better lipid and central nervous system tolerability profile compared to efavirenz overall. But again, there are still some issues with rilpivirine. The oral formulations have some drug-drug interactions, including with acid-reducing medications and PPIs. It does require food for optimal absorption when taken by pill. And there is still a lower genetic barrier to the regimen compared to, for example, the next generation integrases. There's always been concerns with regards to how it's been dosed and whether it's, whether it's quite as potent as some of the other regimens that we now have available. Echavarine was used mostly and continues to be used mostly for individuals who are treatment experienced, many of whom have drug-resistant virus. Again, it's very well tolerated, but it's a twice-daily regimen, lots of potential drug-drug interactions, and there were always concerns about rash as well. So in this context, doravirine became available in 2018 as a new NNRTI with activity against most of the common first-generation resistance mutations that we saw, including this K103, Y181, G190, and then the rilpivirine resistance mutation, which is E138K. Basically, it has an excellent sort of tolerability and safety profile. It's only given once daily. It doesn't require food. It has a very low drug-drug interaction profile and potential, and it's generally well tolerated with a better sort of metabolic and lipid profile compared to something like efavirenz. There's also no need to adjust doravirine in individuals with renal insufficiency, including severe renal insufficiency. And again, the current data, which Bertrand is going to cover in more detail, it looks to at least be weight neutral compared to the common next-generation integrases that we're using at present time. So it's currently recommended as a first-line regimen in the European guidelines alongside sort of the integrase-anchored regimens, and it was approved for use in the United States by the FDA in 2018, as well as by Health Canada shortly thereafter in October of 2018 as well. So that's a brief overview. So with that in mind, I'm going to pass it over to Bertrand, and he is going to take us through our first case and review the metabolics and weight issues with doravirine. Thank you.
Okay. Thank you, Alex. Hello, everyone. If we want to discuss individualizing HIV care, I want to discuss with one of my recent cases, one of my recent patients, that one size does not fit all, and that we need sometimes other choice, other alternative to try to best answer to our patient needs. So this is my conflict of interest disclosure. So, and it's important because we are in a specific context in Canada. In Canada, we are in a specific context where HIV, all around Canada, the HIV incidence increased by 25% in 2022 when you compare to 2021. And in Montreal, where I live and I practice in the McGill University Health Center, the situation is a bit different because we had an increase in 2022 of 120% of new HIV cases. And most of this increase were among migrants population with an increase around 400%. Most of them came the same year in Canada. And it's just part of the situation because actually in my clinic, possibly we receive 2 new cases per day, and most of them, they are already treated. So they are not as new HIV diagnosis. So and it's important because in these cases, in this new situation in Canada, and for me, for my team in Montreal, we have to adapt, and we receive a new population with different needs than the population we saw before. So, and that's why possibly there has never been a better time to individualize HIV therapy. Why? Because actually, thanks to the treatment, thanks to the HIV management we have, HIV is really more and more a chronic condition. But so, of course, we have long-term concern, long-term safety. It could be concern about weight gain, lipid, renal bone toxicity in an aging population who develop also other comorbidity. But also, we need more treatment options. So we have dual therapy, we have long-acting, oral therapy soon, and injectable already. So the problem of comorbidity, of polypharmacy, also the problem of adherence, suboptimal adherence, and it's a major concern in all over Canada. Most of the time is underdiagnosed, and because we have difficulty to really, we need a very good outcome to try to evaluate this adherence. It is difficult, and most of the time it's difficult to have the patient perspective on this trouble of adherence because we don't use in-house patient-reported outcome measure. And of course, trouble of adherence after there is a risk of virologic failure, resistance development. Also, we have the problem of multi-drug resistance. So we have patients with multi-drug resistance. Also, we have patients who are treatment experienced, virologically suppressed, and they need also sometimes simplification because they are under complex treatment. And also, we need also to put more effort to try to improve and to participate to this improvement of health-related quality of life. Because it's not only the efficacy of the treatment of HIV management, it's not only a question of HIV and detectability. We have to go beyond that. And we have really to integrate more and more the perspective and to be sure that our patient can reach a good health-related quality of life. So in this context that I just briefly described, is there a room for a doravirine-based regimen? And also to try if we can continue to individualize our approach for HIV management. So I will present one of my patients. So it's not his picture. Huh? I just find this picture in an open source on the web, just to put some color in my boring slide. So I will discuss this case of, I will explain this as a minimal switch. So it's Mr. P. Mr. P is one of my patients. He's 27 years old. He's from India. The first time I met him, he was a student in a famous university in Montreal. He was diagnosed in India with HIV in 2021 with CD4 around 320, a viral load around 50,000 copies. And he was started with this combination, so the equivalent of Atripla here. The name is Trustiva. So it's a combination of efavirenz, TDF, and emtricitabine. And for sure, when he came in as a student, you know, most of our students, they have a low coverage. So most of the time, they are covered for around $5,000 for the length of their study. So if they will go 2 times in emergency room. There is nothing for their coverage. And most of the time, it doesn't cover the antiretroviral therapy. So he came with 1 year of his antiretroviral therapy. So the first visit with him was in August 2022 in our center as a chronic virus services at McGill. And so we did some blood tests. His renal function was preserved. He was undetectable with good CD4, around 674. And his weight, he was a bit overweight, around 81 kilo. So his first discussion, so I asked him, how is it with your combination? You know, and I was thinking, oh, I wanted, because it's the first time I saw the bottle of Trustiva, so I was a bit interested to see what is the difference with the treatment we can find in Montreal or in Canada. So he told me, and I asked him, oh, how is it with your treatment? Do you have any side effects, any symptoms? And he told me that most of the time I take the treatment around 11 p.m., and 2 hours after, I have dizziness, palpitation during 15 minutes, then insomnia, vivid dreams overnight, sometimes headache. So I asked him, do you want to switch? Do you want something possibly we can decrease or we can resolve these symptoms? So what he told me, okay, if I would love to switch, it will be with I want a single treatment regimen like I have actually. So we discussed integrase inhibitor-based regimen, STR, or non-nucleoside-based regimen. But he was concerned about the potential weight gain. He doesn't want to gain weight. So, but there was very quickly, after a few minutes, the cost consideration. He told me I have no coverage for my treatment, and I have with me 1 year of treatment. So finally, he refused to switch, and he said, okay, no, I will stay like that, and I will come back to see you. So I asked him, if you want, come back in 3 months, and we can rediscuss that, and we can. So finally, he came back 14 months after. So I asked him, he still has some nightmare, dizziness. He's still a bit reluctant to change his treatment, still scared not to be covered. And so during these 14 months, he went back to India on vacation to see his family, and he got more bottle of his combination, of his generic combination. And now he's working. So he has like a temporary work permit, and he has health coverage. So I asked him, possibly it's a good time to reevaluate your treatment and to see if we can do better. And he told me, yes, sometimes also he takes some omeprazole from a friend because he has some GERD. So we discussed, same discussion, what kind of possibility, and he just increased a bit his weight, not too much, around 1 to 2 kilos since the last 14 months. So that's why I tried to summarize my suggestion. So I think if you want, you can switch to doravirine, SweetEC, TDF, or we can also evaluate a switch to BF-TAF or a switch to dolutegravir, SweetEC. So I tried to explain to him what will be the possibility and the advantage and potential disadvantage of this combination. So, you know, I told him, if you have with doravirine, you will stay in the same class, no nucleoside like your current treatment. With BF-TAF or dual therapy, it will be a new class of integrase inhibitor. For all these possibilities, we have no problem with your initial viral load. There is also no food restriction, so that's good. If you go with doravirine-based regimen, you will be with the same backbone. Or if you switch to BF-TAF, you will have a new backbone with TAF. And in the same, all this situation, you will have minimal drug-drug interaction. And also, particularly for doravirine-based regimen, you can use your omeprazole and you can use some acid-releasing agent. So also we discuss the weight concern. So the weight concern, when we discuss, I try to explain to him, you know, what is interesting, efavirenz, TDF, they have like a weight attenuating effect. So possibly they can control a bit your weight. Doravirine, possibly a weight neutral effect. But for sure, bictegravir, TAF, or dolutegravir, it could be a weight neutral, sometimes a weight increase effect. It depends which guidelines you will, or which review you will read. So we discussed that. So why, I think I didn't show him these guidelines, but just to give you more information. If you see the European guidelines, the EACS guidelines, I think they are very interesting because they are more, you know, they are more rich because they try to face more situations than possibly in North America. So the EACS guidelines, most of the time, they are more interesting. And also, even doravirine is part of the first-line therapy, doravirine-based regimen. So they propose more choice. They still continue to integrate also integrase protease inhibitor. So it's interesting. And what they explain for the side effects, so you can see here for the side effects, what they explain that efavirenz, so for sure you have a lot of side effects. You have less side effects with doravirine, sleep disturbance of headache. And also, if you check for the side effects with bictegravir and dolutegravir, weight gain is still part of, even in the last update of the EACS guidelines. If you check after the DHHS guideline, for the American guidelines, so you can see that it could be a significant weight gain with all antiretroviral therapy, but more, it had possibly more pronounced with dolutegravir, bictegravir, and TAF. So that's also the data. And you can see, depending on the guidelines, you will not see exactly the same conclusion. So also, we have data, interesting data from Drive Forward and Drive Ahead. It was presented in 2021 at EACS. And also, I will show you after, it was also published recently as a post-hoc analysis in the Lancet HIV. So what is interesting with this, so for sure, it's two major studies with doravirine, but for treatment-naive adults. So in Drive Forward, there were doravirine plus 2 NRTI, and the control group was with darunavir boosted plus 2 NRTI. And in Drive Ahead, it was doravirine, SweetEC, TDF, so the combination STR, and it was compared as a control group with efavirenz, FTC, TDF. So it's interesting because they were in a randomized phase until week 96, and after there was an open label phase, and all participants can go to the doravirine, to a doravirine-based regimen. So it's interesting because at the end, they have 4 years of follow-up and data on 4 years of follow-up. So what we can see that doravirine-based regimen, they demonstrate in efficacy, so they can maintain the viral suppression over 4 years. If we saw the protocol-defined virologic failure, so in development of resistance, is still relatively low, and also most of the resistance is around 1%. They occur in the first 96 weeks, and after it was very stable. So the stability, this data show a good stability in the long term with doravirine-based regimen. And also we have a good increase in CD4. This, it was not directly from this study, is from the driver-ed study, week 48. So they evaluate the neuropsychiatric adverse effects, side effects, and you can see that with the doravirine-based regimen, you have less dizziness, less sleep disorder and disturbance, and also altered sensorium. So the neuropsychiatric profile is better with a doravirine-based regimen than with an efavirenz-based regimen. So also I discuss this data with my patient because he has this neuropsychiatric side effect with his efavirenz-based regimen. And also here you have the change in weight for driver-ed during the 4 years of follow-up. So you can see that there was a very minimal weight gain, around 2 kilos, and possibly is less than what we will get in the general population. Most of the time in the general population, we say we will gain between 0.5 to 1 kilo per year, okay? Possibly it's a bit less. It could be explained with the TDF effect. But also what is interesting here is you can see here for the, for the population we were on the efavirenz-based regimen, and at week 96, they switched to doravirine-based regimen. So you can see here, they gain a bit more weight, 1-2 kilo more. And it's interesting because possibly it was just explained because they lost the efavirenz effect on their weight. So here is for driver-ed and drive forward for the 4 years data. So you can see that the weight gain was really relatively low, around only 2 kilo in 4 years. So it was Chloe Hawkins and colleagues, they presented and they published all this data in February this year in Lancet HIV. So really they particularly emphasize the good metabolic profile of a doravirine-based regimen with minimal weight gain. And it's interesting also, I think, they emphasize this aspect of the TDF associated weight loss when it's combined with doravirine. So possibly the relatively interesting profile of doravirine-based regimen is more linked with TDF than doravirine. Okay. So what is important also that metabolic health, where inside we can put inside the weight gain, something like that, it's a clinical construct. So it means that it's not only a problem of antiretroviral therapy. It's more, there is a lot of factors. So particularly what we show with the DHHS guidelines. So possibly the weight gain could be a bit more pronounced with dolutegravir, bictegravir, and TAF. Also, it could be also, we have to consider also if we are, is one of your patients is a black woman, because possibly they will be more susceptible to gain weight. Also, it remains unclear, still actually, if the non-INSTI-based regimen could reversal the weight gain. So it's a question of one of your patients is with integrase inhibitor-based regimen. If we switch to a doravirine-based regimen, he will lose weight. It's not clear at all. So also, if you check with IAS USA recommendation, so that's really important. They say document weight and document BMI. Also, the importance of counseling of weight gain and potential cardiometabolic complication, diabetes screening, cardiovascular risk score, but also they emphasize the lifestyle change, and it's the same recommendation even in the EACS, in the European guidelines. So it's very important, particularly if your patient gain more than 5% of his body weight. So also, I just want to show you this data. So it's for when they're actually evaluating doravirine and islatravir. So actually, this treatment is not approved. It's still under evaluation. But it's interesting because it's for a naive treatment population, and they compare with BF-TAF. And the problem we have with doravirine is that the comparator is not actually the first choice, so integrase inhibitor-based regimen. So it's a bit difficult. I know that actually there is an ongoing study with a dolutegravir-based regimen to compare doravirine-based regimen, but we don't have the results yet. So what is interesting here with islatravir and doravirine, because it's compared with BF-TAF. So I just want to show you the data at week 48, the data on the weight. And it's interesting because it's a similar increase of weight increase around 3 kilos and a half. And possibly, so what we can see is possibly it's a return to health effect that could explain this increase. And what we can say is possibly there is a similar effect of doravirine or bictegravir. So I think these data are interesting, and we need for sure more data with a comparator with integrase inhibitor. So very recently, David Hull presented like a review with experts. So they took all the major study on PrEP, but also on treatment initiation for HIV patient, treatment switch, and they discussed together and they tried to make, like a good review, a good comprehensive review on the impact. And what is interesting, they propose a model to show the major factor. We could have a positive or a negative effect on weight gain when we use HIV treatment. So what is interesting here, you can see so you have the return to health weight gain. Here you have the relative underweight. So they try to see if it will be enhanced, it will be neutral or attenuating. And here you have the factor we are not linked with antiretroviral therapy. And here you have the treatment. And what was interesting with the host factor, so you have the pre-treatment viral load, you have the CD4 pre-treatment, particularly with it low. You have female sex, black race, underweight at initiation, and also you have some genetic factor, pharmacogenetic factor. So they can have an enhancing or a neutral effect. And also as attenuating effect, you have opportunistic infection and you have substance use disorder. And what was interesting for them that they evaluate TAF, bictegravir, dolutegravir, and cabotegravir as a neutral effect, and TDF and efavirenz as a weight attenuating effect. So what you can see also that there was not a huge consensus, but we can see that slowly everyone seems to be, they across themselves so we can see what is the impact of weight gain and the impact of antiretroviral therapy on weight gain. So we can come back to Mr. P, my patients. So what we discussed finally, because he told me, I agree to change, but I'm a bit afraid, and so we discussed, he told me, I think I would be interested with the minimal switch. So we discussed that. So he told me, yes, I agree to change, but I told me, yeah, possibly you can change just one of your components. So you will go to efavirenz, sweet EC, TDF to doravirine, sweet EC, TDF. So within the same drug class. And I told him, you know, if you have any problem, we will know the responsible. You know, so it will be good. So finally, we agreed on this minimal switch. Even in the European guidelines, you have they notice this situation, the switch within the same drug class. So they explain that it's usually virologically safe, equal potency, and particularly if there is also absence of resistance. And also he wanted to participate to the DRIVE cohort study, so it's a real-life cohort that was developed by Merck also for every patient who start a doravirine-based regimen or want to switch to a doravirine-based regimen, he can participate. So they evaluate the undetectability after a few weeks, and also they try to evaluate with some patient-reported outcome, try to evaluate some patient perspective. So the evolution, I saw him 10 days ago, and 1 month after he switched to doravirine, sweet EC, TDF. He's still not detected. He's good CD4, and also most of his side effects resolved. So in conclusion of this case, who might benefit the most from doravirine? So doravirine is, I think, is a valuable option for heart, particularly because it has a good metabolic profile. So I have to be honest, doravirine-based regimen is not my first choice most of the time. But I need some second choice, and I need sometimes some good alternative, particularly with this population we receive actually in my center sometimes, and a lot of them are going also with efavirenz-based regimen, and we know that sometimes it's relatively easy to switch to a doravirine-based regimen. So what is the limit? The limit I have with all the data I presented is we have very few data on patient-reported outcome to know what will be. It could be interesting to have more data on what will be the perspective of the patient after this switch, after this initiation, to see if really how they feel and what are their perspectives. So also metabolic health is not only absence of metabolic disease, so it's also a clinical construct. So it's not only metabolic health, it's not only a problem of antiretroviral therapy on what kind of, if I will use doravirine or I will use bictegravir or dolutegravir. No, it's more than that. It's also a question of diet, a question of inequality of health. You know, if most of the migrants, they don't have access to vegetables, they don't have access to fruits. So, you know, so it's difficult for them also to try to maintain an healthy diet. So we have also to include this aspect if really we want to help our patient not to gain weight, if they don't want to gain weight. So also, we need lifestyle intervention. We need sometimes a proactive antiretroviral approach. So that's something also very important. It's your turn.
It is. Thank you, Bertrand. So we're going to move on now, and I'm going to present a couple cases from my clinical setting, which is a little bit different from Bertrand's. So let me begin by telling you a little bit about my practice setting and kind of what's happening. So I practice in Saskatchewan, in southern Saskatchewan. And unfortunately, the province continues to face some difficult challenges. We have the highest rates of HIV and syphilis incidents in the country, and this continues to kind of get worse and not better. And so the epidemiology of HIV transmission in the province has changed over the course of the last several years. So when I started in Regina full-time in 2011, that would have been, 13 years ago, we saw predominantly most individuals newly diagnosed with HIV probably transmitting and acquiring HIV through parenteral means, so sharing of injection paraphernalia, injection drug use, and so forth. And at that time, most of the substance use was via injection with things like cocaine, other stimulants, and prescription opioids. So that dynamic has changed along with the patterns of substance use, and the majority of people up until just recently are inhaling their substance now. So the most common stimulant being used is crystal methamphetamine. The most common opioid is fentanyl and its various derivatives. And again, this is being inhaled. So, back when I started in 2011, we would see very, very high rates of HIV, hepatitis C co-infection in newly diagnosed HIV-positive individuals. And now I see almost none of that. Almost all of the individuals that we see who are newly diagnosed have a negative hepatitis C antibody, so no previous exposure to hepatitis C, but are often co-infected with syphilis and other sexually transmitted infections like chlamydia and gonorrhea. Yeah, we also have unique epidemiology, which hasn't changed since 2011. We continue to have disproportionate representation of individuals who are biological female, young individuals under the age of 40, and persons of First Nations and Métis heritage. A lot of concurrent comorbidities, including persons with substance use disorders, as well as various socioeconomic variabilities, so housing, relationship, income, food insecurity is the norm. So given this entire dynamic, the historical approach that we've had to antiretroviral therapy in our clinical setting has mostly been to focus on thinking about the genetic barrier to resistance, because for a lot of these individuals, we spend a huge amount of time and energy and resources trying to optimize their social circumstances and their different insecurities and vulnerabilities to allow them to hopefully be successful with regards to their oral antiretroviral therapy. And that sometimes works and that sometimes doesn't. So historically, we were kind of using PI-anchored regimens like with atazanavir and then subsequently with darunavir. And we've obviously moved, just as the rest of the world has, to using integrase-based regimens now with things like bictegravir and dolutegravir. So we have had some recent changes. We're seeing higher numbers of individuals now coming to southern Saskatchewan from different parts of the world. Not quite to the same degree, obviously, as places like Montreal or Toronto or Vancouver or Calgary, for example, but definitely seeing more individuals coming from sub-Saharan Africa, coming from Southeast Asia, as well as the Ukraine, on different types of regimens that we wouldn't have had the opportunity to necessarily manage before. Most are coming suppressed, and so this creates some different dynamics. So I'm going to go through a couple of use cases now for doravirine in our particular clinical setting. So I'm going to start with my patient. She is 43. She's Caucasian, and she was diagnosed with HIV in 2015. And at the time she was diagnosed, her CD4 was 326. Her viral load was only about 1,700. She was clade C, and her initial baseline genotyping showed no resistance. So this is kind of like her ART history. It's not that important, but initially in September 2015, shortly after she was diagnosed, she was put on a single tablet regimen of L-vitegravir co-formulated with cobicistat TDF-FTC. This was Stribild, and she was on that for 3 years, did fine with it. And then she had gotten into a new relationship, so she kind of came in 2018 and talked to us about wanting to potentially have kids and get pregnant. So we talked to her about different options, and ultimately we made the decision to switch her to twice daily raltegravir and FTC TDF, or Truvada, and she did become pregnant, deliver a healthy baby girl, just as the pandemic was about to begin in March of 2020. She carried on raltegravir and Truvada for a while longer, and then at that point she talked about wanting to maybe simplify her regimen, go to something once daily, go to less pills, and so we talked about different options, and we switched to BF-TAF. So during the course of the pandemic, I kind of followed her largely remotely. I never really saw her in person. We talked on the phone probably like every few months, and she did her lab work, and she was gaining weight, like progressively gaining like pretty significant amounts of weight. Over the span of about 2 years, she gained over 30% body weight. And so we talked about this. There were clearly some lifestyle-related issues, probably pandemic-related issues kind of going on with exercise and diet and other dynamics, but I kind of wondered in the back of my head about whether or not the switch to BF-TAF, so taking the TDF away, taking the raltegravir away, putting her on BIC, for example, whether or not that may have played some role in all of this as well. And we talked about it and talked about it. We decided to try to give it some time, but ultimately in June of 2022, given the fact that she wasn't wanting to be pregnant at that point and that there were no issues at all from a renal or bone health perspective, we went ahead and switched her to single tablet doravirine 3TC TDF or Delstrigo. So I wanted to take a moment just to kind of go through some of the data, just one presentation that was presented at CROI this past spring. This is from the OPERA cohort. This is a large US cohort comprising over 100 clinics in over 20 US states and territories, and it represents about 15% of all of the individuals in the United States living with HIV. Basically, what they did was a retrospective analysis, and this was a collaboration with Merck, of weight changes in persons living with HIV in the cohort who switched to a doravirine-containing regimen between August of 2018 and December of 2022. And they subsequently looked at this data and they stratified it by a few different factors, including sex, as well as the use of efavirenz and TDF both before and after switch. As Bertrand mentioned, both efavirenz and TDF, I think we all agree, have like a weight attenuating effect. And they also stratified the data based on individuals who maintained either their integrase or TAF use or both before and after switch. Okay, so I'm just going to take you through some pictures here after we go through the baseline characteristics. Key things here, I think, to point out are that there's a relatively high proportion of individuals who are either Black or Hispanic ethnicity, over 50%, and that there were a large proportion of individuals, close to 80%, if you look down at the bottom two lines, who were either overweight or considered obese based on their BMI criteria at the time of switch. So this is the weight data stratified by sex, and so there's 3 lines here. The top line in sort of the dark blue is all of the females in the study. You can see a more significant sort of decline in weight over time spent on doravirine in the female cohort, as opposed to the male cohort where it appears as though the change is relatively modest. And then the line in gray is kind of the overall cohort, representing the fact that there were obviously more males than females in the study. So this one's interesting. I'm going to try and just take this through with you as well. So we're going to start by, so this is weight change for doravirine stratified by the use of either tenofovir or efavirenz, and I'm going to take you through this. We're going to start by looking at the top 2 curves first. So there's that top curve there, and you see sort of like a bit of an increase, and then you see like a decrease, a gradual decrease. Those are individuals who were basically either on TDF or efavirenz before switch to doravirine, and then after they were not on tenofovir or efavirenz. So it kind of makes sense because, again, if we think about TDF and efavirenz as having weight attenuating effects, you take them away, maybe there's some weight gain, but then we see this kind of steady decline, and that's a little bit harder to sort of answer. Is that potentially a doravirine effect? Is that something else? Don't completely know. So then we move to the second curve right below that, which is kind of like an immediate decrease, and then it kind of flattens out a little bit. Those are individuals who were not on TDF or efavirenz before switch to doravirine, but then presumably most of them are on tenofovir disulproxyl fumarate, because you wouldn't normally use efavirenz and doravirine together in the same regimen. So they were then switched to TDF, and then you can see sort of like a decrease. And again, you would expect that to a degree if you add TDF to a regimen. So how much of that is TDF versus how much of that is doravirine? Again, hard to say. And then just kind of looking at the bottom 2 lines, these are individuals who basically were not on TDF or efavirenz either before or after, or were on TDF or efavirenz before and after. There was basically no change at the time of doravirine switch, and you see basically no real significant decrease. If they weren't on anything, there was a bit of a decline, and if they were on either TDF or efavirenz before or after, there was it was a neutral effect overall. So hard to completely know what to make of the data, and how much of this is, I mean, I think some of it is explained by TDF either sort of being on or being off, but at the same time, hard to know how much of this is potentially related to doravirine. This is just the data stratified by the use of integrase and TAF. And again, without going into way too much detail here, it's hard to really see the first two curves, which are kind of up and then down and kind of mirror one another in an opposite manner, are individuals who are not on integrase and then either are not on TAF or on TAF throughout the entire course, regardless of the switch. And again, you don't really see a very clear pattern. You see, some individuals initially kind of gaining weight and then kind of dropping and then kind of bumping up again. Hard to know exactly what's kind of causing that overall effect. When you look at the bottom two lines in green, these are individuals who are on integrase throughout, either on TAF or not on TAF. You see a very modest potential decrease in weight with these groups, but it's modest at best. So in the end, looking at this data, at least from this OPERA cohort, there was about a 0.8 kilogram decrease per year across the entire cohort for individuals who switched to doravirine. This was higher in women compared to men, and the majority of individuals switching to doravirine in the cohort were overweight or obese, as we talked about. And it's not entirely clear how we explain some of these patterns of weight change, whether some of this, I think, is driven by the TDF effect or whether some of this is potentially doravirine specifically. And there was a potential trend towards weight loss in individuals who were on the same integrase and TAF combination, but it was not statistically significant. So as Bertrand mentioned, there's an ongoing ACTG study looking at individuals who are on integrase inhibitors and or TAF who gain significant weight on those regimens, who are then going to be switched to a doravirine-containing regimen. This is a prospective clinical trial that's ongoing right now. I think we expect results sometime next year, and that's going to help us really better answer the question around what the potential impact is going to be if you take somebody that's potentially gained weight either on an integrase or TAF-containing regimen and you switch them, for example, to single-tablet doravirine 3TC and TDF. So let's go back to my patient. So she was switched, as you remember, and she actually did lose some weight. She lost about 6%, which was about 15 pounds of her body weight over a year. And some of this may have been lifestyle driven because she did make some attempt to change some aspects of her lifestyle. But in October, she told me that she was in a new relationship. Things were going pretty well. And they had talked and wanted to potentially try and have a child together and get pregnant again. So we talked a little bit about kind of the data around doravirine. There's not really any clear data showing safety of doravirine in pregnancy. So we talked about different options, and we switched her ultimately back to raltegravir twice daily and Truvada, which she tolerated previously well in the past, and she's still attempting at the present time to get pregnant. I'm going to move on to another individual in my practice now. This gentleman, when he was diagnosed, was in his 60s. He's now in his 70s. And he was diagnosed with HIV in 2012. His initial baseline genotype showed a G190A, which is a resistance mutation to NNRTIs that confers resistance to the first generation NNRTIs like efavirenz and nevirapine. This was a very common circulating mutation that we saw in southern Saskatchewan as almost like our dominant wild type strain for several years when I started in practice. Then it kind of faded away. I thought he was likely to be reasonably adherent to therapy, and when we look at his medical history, he had a background of renal insufficiency. He'd had an MI in 2011, dyslipidemia, and other sort of conditions you can see there, including diabetes and hypertension. So these are his various medications. He's on a statin, blood pressure medications, and a PPI. So here's his ART history. So we started him initially on twice daily raltegravir and co-formulated ABC and 3TC, which was Kyvexa. He did okay with that, but he was questioning whether or not he could simplify his regimen in October of 2016. And so we talked with him and ultimately switched him to co-formulated dolutegravir ABC 3TC, which was Triamec. He had on and off sort of central nervous system type stuff, some insomnia, what he called kind of fogginess or difficulty concentrating at times. It seemed to kind of come and go, and so he persisted with the regimen. He liked the idea of being on less pills and on a single tablet. But ultimately, when we had more open access to BF-TAF through public funding in March of 2019, we ultimately made that switch, and his CNS toxicity largely resolved shortly after that switch. So while all of this was going on, his renal function was gradually getting worse and worse. So when we started together in 2012, his GFR was about 40, and it slowly decreased over the next number of years to about 20 to 22. So he had reached a point where he was starting to proactively start to plan like what we were going to do with regards to renal replacement, or possibly whether or not he was a candidate for renal transplant with his nephrology team. So with that in mind, we thought, okay, well, we need to maybe think about what we're going to do with his ART regimen here as he progressively declines. So what you choose to do with antiretroviral therapy in individuals with reduced kidney function largely depends on how bad their kidneys actually are. And so when we look at the various definitions of kind of mild, moderate, or severe renal insufficiency, it's based on your EGFR. So guidelines would say that if you have mild renal insufficiency, the general approach is to avoid TDF due to the potential for proximal tubular dysfunction. If you have moderate renal insufficiency with a GFR between 30 and 60, then there is prospective data showing that you can use the new form of tenofovir alafenamide, safely, but you don't want to use TDF. And there are a variety of complete regimens that you can use for individuals who fall into this category, either as single tablets or complete regimens that don't require any adjustment for renal insufficiency, like BF-TAF, dolutegravir with TAF-FTC, dolutegravir co-formulated, or just with lamivudine, and then the long-acting cabotegravir and rilpivirine does not need to be adjusted for renal insufficiency in this setting either. Gets a bit more complicated when you have severe renal insufficiency or a GFR less than 30. Kind of then depends on whether or not you're planning for or on dialysis versus not. If you're not on dialysis, the main recommendation is to avoid any type of tenofovir containing regimen of any sort. And if you are on dialysis, then there are some regimens like BF-TAF, dolutegravir, TAF-FTC, which you can use, or you can use dolutegravir with renally dosed lamivudine. So what do we do for our gentleman? It was kind of complicated, and I'm not going to go through all of this, but this is just a list of like all the different options that we potentially had available just purely based on his renal function. And then from there, we kind of took some certain things away. Couldn't really use rilpivirine because of the PPI he was on, his baseline resistance. Same with efavirenz, baseline resistance, worry about his metabolics. Dolutegravir we didn't want to go back to because of the CNS stuff. And then looked at darunavir, again, not optimal because of his metabolics and the lipid piece. And then I didn't want to put him back on abacavir with his previous MI history. So with all that in mind, we ultimately made a decision. These were kind of the agents that are still available and left, and we ultimately switched him, or I switched him, sorry, to doravirine, 100 milligrams once daily, and twice daily raltegravir. He ultimately ended up on hemodialysis, but during that entire time, he maintained virologic suppression. He did very well. He had no blips. I was checking him a bit more often, like every 3 months, as opposed to every 6 months, and he did just fine. So there isn't any prospective clinical trial data looking at doravirine in the context of individuals with severe renal insufficiency or in individuals on hemodialysis, but there is some data that I'll just show you really quickly here. There's one Spanish cohort of about 8 individuals, and this was a PK/PD study where they took 8 individuals living with HIV who were already suppressed on stable ART. They added doravirine once daily for 5 days, and then they did various PK/PD measurements and analyses for these individuals who were on intermittent hemodialysis. And to make a long story short, what they found was that doravirine was moderately extracted by hemodialysis. This extraction ratio was 34.3%. They looked at the ratio of pre-post dialysis concentrations, which was about 0.8 by sort of like a mean measurement. But when you looked at the mean overall plasma concentrations post-dialysis for all these individuals, this number of 785 nanograms per mil was far in excess of the protein-binded adjusted EC50 for doravirine, which is 5. So the conclusion in the study was that even though you see moderate extraction of doravirine with dialysis, it's still going to be safe, and you're not going to require adjustment of doravirine in individuals on IHD at least. There was also a small Japanese study that I'm just going to summarize where they took 4 individuals living with HIV on doravirine-containing regimens who were on IHD, and they were actually, and doravirine was part of their regimens. All of these individuals that were described maintained virologic suppression and did very well with no safety concerns or AEs. So remember that our gentleman had this G190A mutation, which again is a mutation that confers resistance to these first-generation NNRTIs. And so I wanted to take the opportunity just to segue and just present some data, some Canadian data actually, that was presented by Chanson-Broom from the BC Center at EACTS last fall in Poland. So they basically took their entire genotype database from the BC Center, which is almost 40,000 total genotypes, collected amongst 10,000 plus individuals living with HIV in BC, which represented close to 70% of all the individuals living with HIV on antiretroviral therapy in BC during this time frame. Again, this was a collaboration with Merck. And so they looked specifically at all of these genotypes and sequences and what proportion of individuals had previously had exposure to NNRTIs versus not. And then there was a proportion where the data was not clear or unknown, and they presumed that most of these unknown individuals, where they didn't have clear data, were individuals who likely had naive genotypes performed and who were then subsequently placed on suppressive therapy, either with a PI anchor or an INSTI anchor. Okay? And what they did was they wanted to look at the prevalence of NNRTI resistance as well as the prevalence of doravirine resistance overall. So I'll take you through this data really quickly. This is just the NNRTI picture. And essentially, I just want to highlight the fact, and it's not a big surprise, if you look at the top two graphs, the top left is efavirenz, the top right is nevirapine. Not surprisingly, you see more significant resistance and high-level resistance for those two drugs in individuals with NNRTI experience. Again, not a big surprise. Much less so in individuals who have never been exposed to NNRTIs or where their status was unknown. The resistance profiles for etravirine are a lot more modest. And then you can see there's sort of a mix for rilpivirine in terms of the overall resistance seen, again, with most resistance seen in individuals with previous NNRTI exposure. Again, not a big surprise. So this is the doravirine data, and when they looked at all of their sequences, they found about 2%, little over 2% of all the sequences had some type of underlying doravirine resistance, and the majority of this, as you can see in the graph, was seen in individuals with previous NNRTI exposure. Very little was seen in individuals who did not have previous NNRTI exposure or where their NNRTI exposure was unknown. If you look specifically at individuals who received NNRTIs at some point in the past and what the prevalence of doravirine resistance was, it was about 5%. So then they actually took some clinical data from their database. And so at the time of the presentation by Chanson, there were 230 individuals in BC who had started doravirine in some way. And looking at these 230 individuals, 75 of them actually initiated doravirine in the context of some pre-existing NNRTI resistance based on their database analysis. So they asked the question, how did these people do? Like, if you have pre-existing NNRTI resistance, you get put on doravirine, how do you do? Just looking at like what sort of regimens they were on, the majority, close to 2/3, were receiving 4 or more ARVs, not surprising, and only 10 of the 75 were on essentially doravirine plus 2 NRTI backbone. So what they found was that 84%, so 63 of the 75, actually either achieved or maintained virologic suppression after using doravirine for a median of 8 months, despite having pre-existing NNRTI resistance. So this is reasonably reassuring. And of these individuals who initiated doravirine, they looked and they saw that there were 28 individuals where genotyping was ultimately performed, and there were 3 cases of doravirine resistance identified in the 230. So some things just to take home with this Canadian data. Again, the overall prevalence of doravirine-containing mutations was relatively low, only about 2%. 84% of individuals in the cohort who had pre-existing NNRTI resistance who got doravirine maintained or achieved virologic suppression. And finally, looking at the individuals exposed to doravirine, at least based on the timeframes of this study, the overall resistance rates seen were very, very low. So I'm going to move on just to my last case here, and this hopefully may stimulate a little bit of discussion because I don't know what to do with this particular individual, but he's PP. He is PP. He is 74, and he was diagnosed in 2021 after essentially presenting with multiple episodes of clinical manifestations of severe thrombocytopenia. He was referred to hematology, got a workup from them, and HIV was not actually checked. And ultimately, it was an emergency physician who actually did an HIV test on him when he presented with intractable epistaxis or nosebleeds, and that's how he was ultimately identified. So when he was diagnosed, his CD4 was only 455. His viral load was quite high at baseline, close to 9 million. He was clade C, and when we did his genotyping, he had no baseline resistance. So in terms of his medical history, he'd previously had acute coronary syndrome in 2008, and he also had a background of high blood pressure and osteoarthritis. These were his various medications: atorvastatin, atenolol, combination, perindopril, indapamide, and ECASA. So he initially was managed by a colleague of mine, and he was started on BF-TAF shortly after he was diagnosed. Kind of missed the ball and only ended up repeating an HIV viral load on him about 6 months after he initiated BF-TAF, and his viral load had come down, but it was still 506. His CD4 count had increased substantially to 679, so that's definitely a lot better. So our pharmacist and I ended up taking over his care just for a variety of different reasons. But we kind of went through things with him. It was clear that he was not taking his pills as well as he should. He kind of was having some issues remembering on what to take and fills and all the rest of it. So we did a few things. We counseled, provided blister packing through his community pharmacy and some other interventions, and kept in close touch with him, and he kind of self-reported better adherence overall. We decided to monitor him because he was getting a little bit anxious about why he wasn't sort of achieving a suppressed viral load. He wasn't sexually active, at least according to him. And so we decided to monitor him every couple months with viral loads. And this is the pattern here. You can see like 428, 330, 145. Then he kind of blips up again, 330, 353. Okay, so he's kind of just hovering with this kind of low-level viremia. So what do you do? So we thought about all the things that you would normally think about for all the clinicians in the room and pharmacists and so on and so forth. So we think about the things that can lead to low drug levels, obviously adherence is the big one. Then we also think about malabsorption. We think about potential drug-drug interactions, food-drug interactions, and so forth. So we went through all of that with him. We tried to send a genotype, but it wasn't successful. The viral load was too low, so we couldn't amplify his virus. And again, we talked with him about adherence and so forth. He was insistent that he was taking his pills like near perfectly at this point. So no DDIs, no food-drug interactions identified, and he was still pretty uptight and worried about why he wasn't achieving viral suppression. And so ultimately, we kind of talked to him about different options and what we could potentially add. We thought about adding a PI. We ultimately considered and added doravirine to his regimen. We intended to follow him a bit more closely, but for various reasons, he ended up not getting a repeat viral load done until 6 months after initiation of doravirine, and then yippee, his viral load was actually higher at 936. So we left him on his regimen. We sent genotyping off. We were successful this time. There was no mutations or resistance identified. So we talked to him again about adherence. He was insistent that his adherence was close to perfect, and we wanted to actually bring him in for therapeutic drug monitoring levels, but he didn't want to come back in for more blood draws. So in the end, we kind of made some mutual decision making. He was CD4 was still reasonable, so we kind of made a decision along with him to not necessarily monitor as closely, and we made a mutual decision to actually discontinue his doravirine in this context, continue his BF-TAF, and to monitor him a little less frequently, because it was kind of creating some anxiety around sort of, just why we were checking him as often as he was, and why we weren't able to actually achieve viral suppression. Okay, so a bit tricky. So those are some cases just from my practice of situations where doravirine definitely has a place in sort of, modern ART care. And as Bertrand said, like when we're talking with learners and when we're just thinking about what it means to be a good clinician, I think, again, part of being a good clinician, in my mind at least, is trying to think about the individual circumstances of the person that you have in front of you and trying to think about what options are going to fit best for that person. And almost always what that means is that there's different approaches, slightly nuanced approaches that are going to work better for one person compared to another, as opposed to a bit of a brute force, not thoughtful, one-size-fits-all approach. So hopefully we've been able to explain that to all of you today in some ways. We'd be happy to take a little bit of discussion for the last few minutes, but I just wanted to end with our classic slide here as to why we need another NNRTI. And today, again, we've talked about a few different things, including Bertrand's minimal switch case. We've talked about the opportunity to add on doravirine as part of add-on therapy. We've talked about some of the issues around weight change and metabolics and what the potential benefits may or may not be. And in the end, hopefully this encourages all of you in the audience who are seeing patients to be a little bit more thoughtful and mindful about taking a nuanced approach to ART prescribing. Thank you. So we have a few minutes now. I don't know if there are any questions. I guess there is, or any points of discussion, or anybody have suggestions on what to do with my last patient. I have several patients like that who are on integrase, anchored therapy, who are just low-level viremia, won't suppress, but you know, we've done TDM in some of them. They're totally fine. Be happy to take any questions and discuss further. Nobody. Bertrand, do you have any ideas?
No, I think I was very interested with one of your last combination, you know, with BF-TAF and doravirine.
Yep.
Because in my center, and Nancy is here, the pharmacist, possibly she can also explain that, but most of the time we don't have any data of what happens before we saw the patients. Mm-hmm. And sometimes they just arrive with 3 pills. Mm-hmm. 3 pills of the combination with efavirenz, and we don't know how they take them. So it's interesting because sometimes we have no history, and it's difficult. So sometimes just it's good sometimes to mix this, so to stay with the treatment with 2 pills, and to see after, when we will get more information, to see if they have to stay with BF-TAF and doravirine, or we can also simplify. Yes?
Hi, Lisa Barrett from Dalhousie. So I walked in late, Alex, and heard nobody's going to ask a question, so why not?
Why not?
So your last PP gentleman,
mm-hmm.
I wasn't quite sure on what the timeline was, how long that stretch of blippiness was going on, just above 200, between 2 and 400 or 500. But I guess the question is, you've done all the right stuff. You've done the TDM. You've done the
Haven't done TDM.
Oh,
but
he hasn't, but
yeah,
he has done
I tried to do it, but he hasn't done it.
But he's got the de facto genotype, at least one,
yes. Right?
From a low-level viremia on his near-perfect adherence. So what's the thing in the back of your head you're worried about the most? The number? Is he well? Like, is everything else well?
He's fine. He's fine. His CD4 is fine. He's fine. You know, again, I mean, I think there was some anxiety up front, and so that kind of was driving our more close monitoring. And we were in a situation where, again, I wasn't necessarily completely confident that adding something on was necessarily going to help or make a difference. But his anxieties and the shared decision-making process kind of drove this where, okay, we're going to see whether or not this kind of works for you. So that was kind of the motivation for it.
So are you still really worried if you didn't have shared decision-making? Would you still be looking to do something else, or would you just watch him for a bit?
I honestly think it would be nice to have TDM on him just to know. You know, and if his BIC levels were reasonable, then I think at that point, I'd probably be a little less anxious, but again, I don't necessarily have a good, simple, rational way to explain some of this, whether or not he has some quasi-species or reservoir or something else going on. So I'm open to your suggestions.
Yeah, so I'll let the next person say something more intelligent,
Cecile?
But I'd probably just wait.
Yeah, I'd wait too.
So hi. So I totally understand the last patient. We do have a few of these patients who never seems to be able to suppress. And of course, we have some data now that shows that some of these low-level viremia come from clonal expansions of viruses that are defective, with some mutations that have been identified near the 5' LTR region of the genome, and that you wouldn't necessarily capture this in a genotype. So, of course, the concern is this replicative virus, or is it just release of defective particles? Then if we knew that it was defective particles, you have less concern about the potential transmission to other patients from this patients, because at 1,000, you start to be in the zone that is less comforting in terms of
Transmission
you equals you know. So if you have some researcher friends who can do this type of study on this virus to see if it is a case of a clonal, that could help answer questions and maybe reassure.
Thanks, Cecile. Any other points or questions? Then I want to thank all of you for the opportunity, and again, for me personally and for Bertrand, we're grateful for the opportunity to present to all of you, and we're excited to begin the conference shortly, and have a great CAHR 2024. Thank you.
All right.